Hello, everyone. I'm just waiting until more participants are joined, and then we'll start in just a minute or two. Okay, so welcome everyone to this Lessons in Bronchiectasis webinar on physiotherapy and airway clearance. And today we have two wonderful speakers and a presenter and a discussant. So we have, before I introduce the participants and the discussant, I want to let you know about the speech to text availability. There are translations available. So you have to click on the show captions to activate, and then right click and choose your target language. Leave the speaking language as it is, English. And there's more languages, so you can search for your own language. And I will now start the meeting. My name is Michal Steinberg. I'm a pulmonologist from Haifa, Israel, and a member of the Embark Management Bronchiectasis Registry. And I'm really happy to open this webinar in the Lessons in Bronchiectasis series. It's airway clearance and pulmonary rehabilitation in bronchiectasis. And the presenter is Dr. Beatriz Herrero-Corina. The discussant is Arietta Spinou. And just a second. So Beatriz Herrero-Corina is a respiratory physiotherapist working in Miguel Servet University Hospital and lecturer at the San Jorge University in Spain. Please correct me if I don't pronounce right.
It's perfect.
And Dr. Arietta Spinou is a lecturer in cardiorespiratory physiotherapy, practice and research at King's College London, and she has a special interest in cough, airway clearance, and quality of life for people with bronchiectasis. And Arietta and I have collaborated a great deal on some ELF and Embark projects, and also in the task force for the guidelines, that's upcoming guidelines. So I'm handing over to Dr. Spinou and then to Dr. Herrero.
Hello, everyone, and thank you for the invitation to join this webinar today. So I'm very pleased to be with you and with Dr. Beatriz Herrero-Corina, who was also my co-chair to the recent ERS task force statement for airway clearance techniques in adults with bronchiectasis. So today we're going to discuss about airway clearance and pulmonary rehabilitation in bronchiectasis, and Beatriz has prepared some very exciting case studies that we can review and discuss together. So welcome everyone, and I hope you have a really good interactive session. Over to you, Beatriz.
Thank you so much, Michal. Thank you so much, Arietta. It's a pleasure to be here. I have the opportunity to discuss about airway clearance and pulmonary rehabilitation in people with bronchiectasis. However, before starting our talk, we want to know more about the audience. So please try to tell us where are you from. Thank you, Kaya, for launch the ball. So maybe you are from Europe, Asia, or Australia, New Zealand. So if this is the case, good night. Thank you for taking time to be with us on North America, South America, or Africa. Just a second to know the results. Not sure if we have the chance to see the results. Yeah, Most of you are from Northern Europe and Southern Europe, some of you from Asia and North America as well. Thank you so much. So if we are basing our management of people with bronchiectasis in treatable traits, we need to pay attention to the respiratory traits, the extrapulmonary traits, and also the lifestyle of our patients. And the airway clearance management using mucoactive drugs and airway clearance techniques and also pulmonary rehabilitation are a good strategies to address these treatable traits. So the main objective of this talk is to learn a bit more about these strategies that can improve the quality of life of our patients and improve the clinical outcomes. So this is our first clinical case. She is Maria, she's from Spain, she's 68 years old. The etiology is not clear, but it's labeled as idiopathic. The main comorbidities are low back pain and reflux. She has a chronic airway infection by Haemophilus influenza. The last year, she had 3 exacerbations, 1 required hospital admission, and the main symptoms are cough, expectoration, activity-related dyspnea, and wheezes. And the bronchiectasis severity index is 11, so it's classified as severe. The last 6-minute walking test provides information that she walked around 68% of credits. The daily steps are almost 8,000 steps per day, and the sedentary time is around 6 hours. In order to assess the impact of cough on the daily life, we use the latest circle questionnaire. It's a validated questionnaire in bronchiectasis, and it ranges from 3 to 21. Lower scores represent a higher impact of cough on daily life. Our patient had a 11.7 score in this questionnaire, and the dyspnea evaluated using the Modified Medical Research Council, it's 1. In addition, we know that this patient completed a pulmonary rehabilitation program in 2022. She learned how to breathe in a different way and also to expectorate using forced expiratory maneuvers or coughing maneuvers. Right now, the pharmacological treatment is optimized, and she referred that she's adherent to exercise, but not to airway clearance techniques because she feels that this type of techniques are not really effective to improve the expectoration. So here it's our first question. What could be your approach? Only one choice is allowed. There is not correct or not correct answer, so you can choose one. The first one, it could be you want to teach another airway clearance techniques, for example, an active cycle of breathing technique. Maybe you prefer to try with oscillating tip devices, or maybe with the autogenic drainage, or maybe with the slow expiration with glottis opening in lateral posture, or maybe you make the decision to maintain exercise as her airway clearance techniques. We would like to know your opinion about that, and when we have the results, we can discuss a bit more about that.
So while people would like to remind you that we really value not only your poll answers, but also any comment or question that you might have. So please feel free to post in the chat, and we'll try to read throughout this webinar.
Most of you choose to start using an oscillating device, and the rest of you make the decision to use active cycle breathing technique. And lower people choose autogenic drainage and the slow expiration with glottis opening. Thank you. So here it is clear that we have a sputum-related symptom burden because we have cough and expectoration and wheezes and activity-related dyspnea. So maybe our approach is to try to change the airway clearance techniques. Most of you choose devices, and I think it's a good option for that because maybe we need to take into account the comorbidities that have our patients. And also the severity of the disease. And what could we expect? So, yeah.
Before you go on, Beatriz, do you have a comment of what would you select in this case? And maybe we can discuss a little bit about the different options and the outcome from the voting.
Yeah, my first option maybe would not be a PIP devices, because maybe I would choose, first of all, autogenic drainage or slow expiration with glottis opening lateral posture, only to understand if with this different approach, my patient is going to be more adherent before starting to buy a device for that. But this patient is from Spain, and I'm from Spain, and we are going to see that maybe the election, the choice of the actives of the techniques, it depends of your geographical location. But I agree that a device it could be good for our patient. It's true that if we pay attention in the comorbidities, the slow expiration with glottis opening lateral posture maybe is not the best one, and we need some adaptations for that, because a sad lying position maybe is not good for her. But this would be my choice. And
yeah,
you?
yeah, that's very interesting. I think I would go first for the active cycle of breathing techniques, but as you said, the where you are based is quite important on how you select these techniques. So I think this would be mainly because of the influence of the British Thoracic Society guidelines in bronchiectasis, which suggest you try first a technique, and then this is not effective enough, you go towards a PEP device. But I think it's interesting to see that most of the participants today would go for a PEP device straight away. So that's, and there is, as you said, no wrong answer. And we know that evidence are showing that the techniques are equally effective. So it does come down to the preference of the physiotherapist and the patient maybe. So maybe we can ask Maria, have you tried that? Or would you think you could use a device more than doing something with your own breathing and this kind of thing? So it's a very interesting discussion, and see how people are addressing that from different areas.
Exactly. So when we refer our patients to our clearance techniques treatment, we are looking for improvement in quality of life, but particularly in cough-related of quality of life. Also, we could increase the sputum expectoration during session, and like that, we can reduce the need to expectorate after that, and also maybe we can reduce the exacerbation frequency. However, I would like to highlight that with this strategy, with this approach, we don't expect changes in functional exercise capacity. And the European respiratory guidelines recommend the use of fiber clearance techniques in people with bronchiectasis, with chronic productive cough, or difficulty to expectorate sputum, and it has to be trained by a respiratory physiotherapy. It is true that the recommendation is still weak and with low quality of evidence, but the main reason is because we don't have so much long-term trials evaluating or comparing the effects of fiber clearance techniques versus no treatment or versus some intervention. And this recommendation is in line with the rest of clinical guidelines in bronchiectasis, and all of them highlight that the first line to control the sputum-related symptoms has to be fiber clearance techniques. But what happens in the real life? Here recently was published data from the EMBARK registry. We have almost 17,000 people, and 72% of them reported that they have daily sputum expectoration. Only 52% of them use regular airway clearance management, and these populations seem to be more likely to be female, non-smoker, non-COPD, greater score in the bronchiectasis severity index, greater use of pharmacological treatment, and lower quality of life evaluated by the respiratory domain of the quality of life of bronchiectasis. And these data are in line with previous data that we have from the Northern Ireland and also from the USA bronchiectasis registry. It is true that we have lower sample size, but the population here that use regular use of airway clearance management, it's a quick return from 73 to 86% of them. But again, this population seem to have more exacerbation, more hospitalization, and lower quality of life. So it's clear that we are using this treatment when we don't have control of the disease and when we have poor clinical outcomes. So it's not using as a preventive approach. And finally, we have also data from the survey conducted by European Lung Foundation in collaboration with Embark. We have response from 1,760 participants from 40 different countries, and 82% of them reported to have daily cough, but only 62% of them were referred to airway clearance treatment. And what could be the problem? What is the problem to refer to airway clearance techniques? Maybe because we don't know exactly how to implement this treatment, because only the British guidelines reported a bit more information about how to implement it. In fact, the British guidelines recommended that respiratory physiotherapy is the best health research, the best health professional that has to teach the airway clearance techniques, with an initial appointment after the diagnosis and a review appointment within 3 months after the diagnosis. It's also recommended to have annual clinical review, and the frequency has to be tolerated, 1 or 2 per day according to the patient's characteristics. And it's important, if we detect a clinical deterioration or maybe a frequent exacerbation, at the same time that maybe we are thinking to change pharmacological treatment, we need to review the airway clearance techniques. And also, if our patients have an acute exacerbation, maybe we need to change the frequency. And if they are admitted to the hospital, they need to receive daily sessions. But how to select the most appropriate airway clearance techniques? In theory, it seems simple because all the guidelines recommended that we need to take into account the patient's symptoms, the patient characteristics, the physical capability, the patient adherence, the patient preference. But in practice, to follow up an algorithm, how to select the most airway clearance technique, maybe it's a more complex decision. And maybe, as we discussed earlier, where do you live? It could be another variable. So here again, we have the data from the Embark, and as you can see in the heat maps, warm colors represent that you are doing this specific technique or you are using this specific device in higher percentage. So as you can see, there are a lot of variability according to your country. And if you let me, I'm going to highlight 2 examples. The first one is the cold technique. As you already know, is the only technique that we have solid evidence at long term that works in people with bronchiectasis. However, it seems that it only is applied in France, in Italy, and Spain. And the same for the devices. The high-frequency chest wall oscillation is really popular in USA. However, here in Europe, it seems that it's not really used for our patients. So I think we need to have a more effort in order to avoid that my knowledge and previous experience of airway clearance techniques, it's determined to choose the best appropriate airway clearance techniques. So our take-home message from Maria could be the patients with respiratory-related symptoms that negatively impact their quality of life of social interaction are the best candidates for this treatment. It is clear that airway clearance techniques is poorly used, and regular use of this treatment is related with poor outcomes. So we are not using airway clearance techniques as a preventive approach. We need to improve the referral to airway clearance techniques, and we need to make an effort to try to standardize a bit more how to select the most appropriate airway clearance techniques and reduce the geographical variability.
Yes, thank you, Beatriz. Before we go on, so I think you demonstrated really nicely how different resources in terms of audits from different countries indicate that we are not doing enough in terms of the airway clearance so far for the patients who need that, and also the importance of airway clearance techniques for this specific case study, which would be your priority versus exercise in this case. So that's interesting. And do you have a comment about the geographical variability? Is there anything that you would consider could improve that in terms of how we can work as professionals towards something that is more standardized?
I think the educational approach is a key point, because it is true that maybe if you live in Northern Europe, the active cycle breathing technique is the most popular technique. However, for example, in the south of Europe, it could be autogenic drainage on the slow expiration with glottis operating lateral posture, and it's because the education could be different between countries. So our effort, it will be to try to be more homogeneous about how we learn and how we teach the different airway clearance techniques, because if I'm not confident with this technique, I'm not going to teach this technique, so the patients maybe are not able to know this technique. And as you already know, Arietta, one of the more important things to maintain a long-term adherence is to provide more than one option to our patients. So maybe if we have a wide type of airway clearance techniques, we can provide different options to our patients.
And I see there's a question or two in the chat, in the Q&A. Would you professionals would like to answer that about adherence on PEP devices rather than ACBT? And there's Joanna that comments that her own personal experience is that PEP device, people are more adherent to PEP device.
Beatriz, would you like, to say?
I completely agree that using a device may improve the adherence, because in fact the patients can have a small feedback about their performance, it is true. But it's also, we need to take into account that the cost of the device, and this device has to be replaced. So at least from my clinical point of view, I usually start with a self-administered airway clearance techniques. And if the patient feel that it works, I usually combine this technique with a PEP device, oscillating PEP device, of course. But the cost is something that I usually take into account with my patients.
Yeah, and similar for me, Beatriz and Michael, and I think there is also the element of cleaning the device and having it with you when you need it, which of course might be minor for some individuals, but it really depends. So it's much more accessible and easy to do something that you don't require any equipment. But on the other hand, you get this feedback that Beatriz mentioned about you've done something physically and you can see that you can get this, for example, vibration or something from your device that gives you a sense of completion and I've made it correct, which you don't have that in a technique that you perform independently. And of course, you have your reviews with your experts and the physiotherapist that can be in specific time points, but you don't have this constant feedback of I've done that correct or not. So it does affect the adherence in some points that you get this immediate understanding if something is wrong.
So here we have our second clinical case. Now it's Sophia. She is 38 years old. She's diagnosed by primary ciliary dyskinesia. She's classified as mild following the Bronchiectasis Severity Index. The comorbidities are rhinosinusitis and urinary incontinence. She has a chronic airway infection by Pseudomonas aeruginosa. Only one exacerbation the last year. And right now the chronic symptoms are cough and expectoration. As you can see, the exercise capacity is preserved. The daily steps are around 13,000 and the sedentary time 4 hours. Using the Leicester Code questionnaire, we have a total score of 9.7 and we have 0 for the Modified Medical Research Council. In a brief interview, we can see that coughing impacts really in the social life of this patient. She feels embarrassed and she feels that the disease controls her. The pharmacological treatment is optimized. She knows how to perform airway clearance techniques. In fact, it's prescribed twice daily, and she started the treatment 8 years ago. She usually performs active cycle breathing technique and also in combination with oscillating devices. And the self-adherence reported it's about 40–50% of the sessions prescribed. So here is our second poll. What will be your approach? Change the airway clearance techniques to mucoactive drugs, or maybe you choose to add mucoactive drugs to the daily treatment, or first of all, review airway clearance techniques performance and change if it's needed, reduce the airway clearance techniques prescription to only once daily, or maybe refer to a pulmonary rehabilitation program.
I think you've made it challenging with only one option allowed there, Beatriz, so it's a bit tricky. I'm very curious to see what people believe on this one.
This is the game. Remember, there is not a correct or wrong answer. It's only to understand better your opinions about how to manage our patients.
And whilst people decide on that, there is also a comment from Joanna Santos about combination of techniques and teaching actually 2 or 3 techniques to a patient in order to see what works for them best. And I think lots of lots of physios are doing that, which is appropriate to tailor to your participant.
Now we have the results. 67% of you choose to review the airway clearance techniques performance and change if it's needed. And 22% of you maybe will add mucoactive drugs to their daily treatment. Okay, I completely agree with you. First of all, maybe we have to review the airway clearance techniques performance, but however, maybe our patient is able to perform correctly the techniques, but it's something else. Maybe, for example, the physical properties of these samples, these sputum, are not good, so the airway clearance techniques are not really effective, and maybe we need an additional help using mucoactive drugs. But I completely agree with you. The first option could be to review the airway clearance techniques. And if we use mucoactive drugs, we expect to increase the sputum expectoration during the sessions and again to reduce the need to expectorate the rest of the day. So maybe we can improve the social interaction. Thanks to that. We also may change the biophysical properties of the mucus layers. So like that, maybe we enhance the effectiveness of airway clearance techniques. We may improve the quality of life and the cough-related quality of life and also reduce the exacerbation frequency, but it is true that we have controversial findings about that. And again, I would like to highlight that we don't expect to change functional exercise capacity.
Before you move on, sorry to interrupt that, but I think that's important in this case because I'm really thinking about the urinary continence for this patient. And that might have a really big impact in how often they perform their airway clearance, because I would be very uncomfortable to do that. So fully agree with the selections. I think we should add on that management of the urinary incontinence would be really, really key as well to help them perform any airway clearance technique. Do you agree, Beatriz, on that? Were you thinking that when you were developing this case study?
Yeah, this is the key. The key. At the end, this patient maybe she needs to expectorate, but at the same time, she tried to avoid that because the problem. So it's a priority to refer to a specialized to improve these symptoms. I think it's really important for her if we want to achieve good results using airway clearance management.
Yeah, and you see that in the Leicester Calf questionnaire also, because it was quite low, the impact which could be related to this, and it could be really making a difference. So really good to see that in your case.
Yeah. So the clinical guidelines recommend the use of mucoactive treatment for adult patients with bronchiectasis that have difficulty in expectorating sputum and poor quality of life, but only after trying airway clearance techniques. And it is in line with the rest of guidelines that the first line of treatment, it has to be airway clearance techniques. And then if we have a high sputum-related symptom burden, and maybe we have a patient with a lot of exacerbations, we can try to add mucoactive drugs as a second treatment line. And all of the guidelines highlight that we need to use a bronchodilator before starting the inhalation of a hyperosmolar solution, and always in combination with airway clearance techniques. And also, it's important to highlight that we need to perform a tolerability test in the hospital before starting to use this treatment routinely. And here we have the data from the EMBARK registry. And as you can see, 28 of the patients use regularly mucoactive drugs. The most popular, it seems to be carbocysteine, followed by isotonic saline and hypertonic saline in 9% of them. And I would like to highlight that from the 28% of people who use mucoactive drugs, 23 of them only use mucoactive drugs. So we are not following the clinical guidelines in this case. And here again, we have the heat map about the variability of the using of mucoactive drugs as well. And in this specific case, I think we need to highlight the problem with adherence. So it was only 50% of the daily prescribed, the sessions prescribed. So it's important that maybe we pay attention to identify the barriers and enables to airway clearance management in these patients. So for example, the main barriers for airway clearance management is the time and the treatment burden. So maybe we need to pay attention about that, and also to understand better the beliefs, the mood and the motivation of our patient. And if we need a psychological support, we have to ask for that, because maybe it helps us to improve the adherence, and to work as well about the feeling, because remember, the result of airway clearance management is to cough up, and it's not a good feeling for our patient, and it's a bad reminder that something is not well in your lungs. Also, we need to evaluate the accessibility, not only to respiratory physiotherapists, also the accessibility to replace periodically the devices, and also to check if the quality of the performance of the airway clearance techniques is good, and maybe we need to change over time these techniques, particularly if our patients have an exacerbation. But also we need to identify the potential enablers to adherence to airway clearance management. Try to give the patients self-management airway clearance techniques, and individualize according to the patient characteristics, also because we want to empower our patients. Also, we need to review the quality of the performance of our patients. So maybe it's time to use telehealth for that in order to achieve this goal. Not forget to introduce education. Like in a pulmonary rehabilitation program, an essential part is education. I think for airway clearance techniques or for airway clearance management is the same. And if we had the opportunity to get support for family or other patients, it's going to be okay. It's going to be good for enable to long-term adherence. So our take-home message could be patients with sputum-related symptoms that negatively impact the quality of life and social interaction are the best candidate to mucoactive drugs, but only after reviewing our clearance techniques. It's highly recommended to include a tolerability test in the hospital before starting to use hyperosmolar agents, and maybe it's good to monitor the intensity of the minor adverse events that we have using this treatment. And further research is needed according to the use of mucoactive drugs in people with bronchiectasis. Can I start with the next one?
So for your take-home message from this study, Beatriz, would you say, for me, it would be like start the airway clearance techniques and then add the hyperosmolar agent. Do you have any other points that you would like the attendees today to keep from this?
Yeah, from this case, from my point of view, the first thing to do is to start listening the patient, just to identify the enablers and barriers to adherence. Because if we don't understand that, maybe it's difficult to provide a good strategy at long term. So remember, it's a behavior change, so we need to pay attention about that. And then I will review the airway clearance techniques. And then if it's not enough, I will provide mucoactive drugs if the respiratory physician agree with this approach, of course.
That's an excellent point. So we go back to the basic. Really, really listen to the person you have in front of you and see what are the things that they have to say to you and the needs they have. So I think that's enough for all of us. Yeah.
And I think, I think about this this case, there's an excellent comment in the chat about addressing the upper airways as well, because especially PCD almost always have chronic rhinosinusitis, and frequently a lot of patients with bronchiectasis have this comorbidity, and they have more sputum and more cough, and you need to treat that as well. Okay.
Yeah, good point, Michelle. In fact, it's not evaluated in the clinical case, but I'm sure that she will have that. Yeah.
So thank you, Lucy, for highlighting that.
Excellent point. Yes. And airways don't have any barriers, so everything is related, upper and lower airways. It's an excellent point to look at.
And here we have our last clinical case. He's Arthur. He's 65 years old. Her main comorbidity is chronic heart failure. He's classified as severe, based on the Bronchiectasis Severity Index, and the etiology is level COPD. He had 4 exacerbations last year, 2 needed hospital admission, and 1 of them required non-invasive ventilation during 4 days. And the chronic symptoms are dyspnea, fatigue, cough, and expectoration. After the last hospital admission, now he requires long-term oxygen therapy and nocturnal non-invasive ventilation. Right now, after the hospitalization, the pharmacological treatment is optimized. And for the exercise capacity, we can see that it's impaired. He walked 48% of credits. The number of daily steps are 3,500, and the sedentary time around 11 hours. The LCQ, the total score of the LCQ is 16.6, and the modified medical research council is 3. She has never been referred to a respiratory physiotherapy. So here is the next poll. What could be your approach? Teach an airway clearance techniques, teach airway clearance techniques and adding mucoactive drugs, refer to a pulmonary rehabilitation program, offer strategies to increase physical activity level, or maintain the same management because right now the pharmacological treatment is optimized. Waiting for your results. What will be your option, Arietta?
Oh, that's a good one. So they've never been referred to respiratory physiotherapy. And to me, having a patient with a chronic obstructive pulmonary disease is straight pulmonary rehab in a way. So I think I would go initially for the answer that the majority of the participants today have voted for. And then in the educational section of the pulmonary rehabilitation, there will be ideally some education about airway clearance, and they can start from there. But what would you do?
Yeah, it's a great point. It's clear that these patients need to be referred to pulmonary rehabilitation, trying to improve the exercise capacity and also maybe to control the number of exacerbation. But we are going to see the benefits of exercise in bronchiectasis. Fortunately, they are clear because we improve the functional exercise capacity, and this improvement is usually greater than the minimal clinical important difference. Doesn't matter if you use a maximal or submaximal test. The exercise also improves quality of life and reduce symptoms, particularly dyspnea and fatigue. And also, you can reduce the exacerbation frequency. It is true that in people with bronchiectasis, seems that exercise not change the cough-related quality of life, and we don't have change in anxiety and depression. That is different from others chronic respiratory disease. The European...
Yep, very quick comment. And in terms of having evidence about the effectiveness of pulmonary rehabilitation in people with bronchiectasis, we know that it's equally effective with the programs that we deliver to people with chronic obstructive pulmonary disease, where it's like the first line of care. So we see that this is really important for people with bronchiectasis as well.
Mm-hmm. The European Respiratory Guidelines recommend to refer our patients to a pulmonary rehabilitation program if they have an impaired exercise capacity. And in fact, the recommendation here is strong with high quality of evidence, so there is no doubt about that. And it's in line with the rest of the clinical guidelines in bronchiectasis. So it seems that all of our patients have to be referred. And as you already know, the components of a pulmonary rehabilitation, the essentials are two, the endurance training and the resistance training. But as you suggested, Arietta, in people with bronchiectasis, maybe we need to pay attention to the desirable components of pulmonary rehabilitation. Maybe we need to have an approach about the airway clearance techniques. I think it's a good opportunity to teach people airway clearance techniques at the same time that we improve exercise capacity. But I think the approach has to be individualized. And we already know that pulmonary rehabilitation, usually it's in a group. So it's a challenge, but it's a good opportunity to try to do that. And also thinking about other modalities to improve the accessibility to pulmonary rehabilitation programs to our patients with bronchiectasis. And what happens in the real life? Using the data from the survey conducted by the European Lung Foundation in collaboration with EMBARC, we know that 20% of the patients were referred to pulmonary rehabilitation. Most the characteristics of these participants are they are more severe, with a higher score of modified medical research council, and they are older. And from the preliminary results in the EMBARC registry, we know that 32% of the participants were referred to a pulmonary rehabilitation program. Most of them have the level of COPD. They have lower lung function and higher dyspnea. And as you already explained, we have a really nice study using a propensity matched study using clinical data. And we included 213 participants of COPD and bronchiectasis. And as you can see in the table, the clinical response to pulmonary rehabilitation is similar between bronchiectasis and COPD, except for fatigue, because maybe this symptom is greater in people with COPD. And the completion rate is also similar between COPD and bronchiectasis. So we have evidence that the benefits are similar to other chronic respiratory disease that usually are referred to a pulmonary rehabilitation program. So the take-home message could be pulmonary rehabilitation is strongly recommended with high quality of evidence by all the guidelines. So there is no doubt about that. And we need to improve the accessibility and refer to our patients to a pulmonary rehabilitation program. The completion rate and clinical response is similar to other respiratory disease. And pulmonary rehabilitation, it's an opportunity to address airway clearance management, but maybe it requires an individualized approach and different from other respiratory disease.
Yeah, I think I ran ahead a little bit, Beatriz, because you actually saw the study I was thinking about, the propensity matching, where they were comparing head to head in the same program, the patients with bronchiectasis and those with COPD. And there is also a comment from Matthew Welch about teaching airway clearance techniques whilst you're waiting for pulmonary rehabilitation. And then, yes, absolutely, you would do that if you have the opportunity to see the patient before that. If you don't, and they have been referred to management, then you go for the pulmonary first. Can I quickly go? I know you have a tweak in this case next, right? You have one more case?
Yeah, it's
yes.
the same case, but a bit different.
Yeah, before I saw one of your options was airway clearance management plus mucolytics, and we have a question which was referring back to the previous case, but maybe this is also a case where you would consider as well using mucolytics if cough is a huge, a major issue for this patient. So Rachel Garrold, hello and thanks for joining us, who is an expert in pulmonary rehabilitation, is asking what mucolytic drugs do you recommend for this patient? So do you have like something you would start with, Beatriz, when it comes to airway clearance management? So I'll get you slightly back to the
In
airway
fact,
clearance.
for this patient, before starting to think about mucoactive drugs, I would start with airway clearance techniques because he has never been referred to a respiratory physiotherapist. So he doesn't know how to perform airway clearance techniques. It is true with his clinical characteristics, maybe the hyperosmolar agents are not well tolerated because we don't know the lung function, but we can think that the lung function is impairment and the severity of the disease. So maybe it's not a good option starting with hyperosmolar agents. But before starting to use mucoactive drugs, I would start again with the airway clearance techniques. And also, sorry, Arietta, and also, if this patient start to do exercise, we can combine the effects of exercise and airway clearance techniques, and maybe we don't have any problems about the Spinou-related symptoms. In fact, I don't remember well, but the LCQ was not so small. So for his patient, the Spinou expectoration is not a real problem.
So if I can summarize this and correct me if I'm wrong, then you optimize, of course, for this case, exercise capacity and airway clearance, which would be airway clearance techniques first for all the cases you've presented, and then you go for the hyperosmolar agents, and then you're considering first the hyperosmolar agents if they don't have any contraindications in the way, right? In a way. And if they have contraindications, then you go for something which is much less triggering this adverse effects. But this would be what you're thinking first as a mucoactive agent.
Yeah, it's like that. Yeah.
Thank you.
So we can finish with Arthur. Now she completed the pulmonary rehabilitation program. So as you can see, we improved the exercise capacity. Right now, he is able to walk 61% of credits. The number of daily steps are right now 3,741 steps per day, and the sedentary times goes from 11 to 10 hours. Here, as you can see, we improved the Leicester Code questionnaire, in fact, an improvement greater than the minimum important difference. And we also improved this NEA. So what could be your approach? Again, are similar the answers: teach airway clearance techniques, and adding mucoactive drugs, refer again to a pulmonary rehabilitation program in 6 months and 1 year, offer strategies to increase physical activity level, or maybe maintain the same management. We are waiting for your results. 50% of you choose to offer strategies to increase physical activity level. 21, if we have the opportunity to refer again to a pulmonary rehabilitation, a pulmonary rehabilitation program. But the accessibility is it's not easy, the pulmonary rehabilitation program. So do it twice per year, it could be a big challenge.
Yeah, and I think in some settings, this is not offered at all as an option, right? So you need to have completed, for instance, a year before you're able to rejoin. So it depends on the providers.
So Arthur, it's a clear example that when we perform a pulmonary rehabilitation program, we probably improve exercise capacity, but this improvement is not always, it's not the same improvement in physical activity and sedentary behavior. So it's clear that here we can try to make a big difference. We can try to improve these outcomes. Because we have a big challenge with pulmonary rehabilitation. We lost the benefits after the completion of a pulmonary rehabilitation program. And here there are two nice examples. The first one, it's a hospital-based pulmonary rehabilitation in people with bronchiectasis. As you can see, after 8 weeks of pulmonary rehabilitation, we have a greater improvement in the exercise capacity evaluated with the 6-minute walking test and incremental Sunday walking test. However, during the follow-up at 6 months and 12 months, we lost these benefits and we started more or less at the same level that at the beginning. And here we have another example. Here it's a home-based pulmonary rehabilitation in people with bronchiectasis. And as you can see, after the rehabilitation program, we improve exercise capacity and peripheral muscle strength. We don't have any effect on daily steps, but these benefits are losing after the follow-up period, in this case at 6 months. So we have a challenge because we don't maintain the benefits obtained after completion of pulmonary rehabilitations. But this challenge is also for all respiratory disease, for example, in COPD, and maybe we have to start thinking about physical activity as well in people with bronchiectasis, and I think it's matter. Here we have a nice picture about the number of steps of people with severe asthma, with bronchiectasis, COPD, and healthy people. And as you can see, it is true that people with bronchiectasis are more bit active than people with COPD, but less active than healthy people. And here in this cross-sectional study conducted by Judy Bradley, we can see that we have information about the exercise capacity, the physical activity, and the sedentary behavior, but stratified according to the disease severity based on the bronchiectasis severity. And it is clear that we have a difference in exercise capacity and also in daily steps. However, we don't have any difference in the time that our patients spend with a sedentary behavior. So sedentary behavior is something that we can change independently of the disease severity. And I think it matters because here in this nice prospective study conducted in Spain, we can see that in the model to assess the risk of hospital admission, low physical activity and sedentary time are two outcomes really associated with the probability to have an hospital admission. However, when we adjusted the model, only the sedentary time is the only predictor to have a hospital admission. So I think it matters in people with bronchiectasis. And the take-home message for this case, it could be maintain the long-term effects of a pulmonary rehabilitation program is a big challenge. Physical activity promotion may be an optimal strategy to maintain the pulmonary rehabilitation benefits. A sedentary lifestyle may be more related to patient's behavior than to disease severity. So maybe we need to pay attention about that and try to change it. Sedentary time is associated with hospital admission in bronchiectasis, and we think that we need further research in bronchiectasis because right now the information about physical activity and sedentary time is really limited in this population in comparison with, for example, with COPD patients.
Thank you so much. Sorry, go ahead. Thanks so much, Beatriz. They were all very, very interesting cases and really starting points for discussions. There are a couple of more questions in the chat that I think they're more generic. So, Mikhail, would you like to start about the hypertonic cell line?
Okay. So the guidelines recommend doing spirometry before and after administration of hypertonic saline, and I just can comment from my own experience that I used to do it, but during the COVID pandemic, it really was very challenging to do. And then we prescribed bronchodilators before hypertonic saline, and then just told prescribed without doing a challenge in the clinic or hospital. And we never went back to doing it because we saw that it was fine in almost all of the people, and we didn't have any bronchospasm. So after the pandemic was over, we didn't go back to doing a challenge. And so I don't do it.
Beatriz, the question was about hypertonic cell line and if it's essential to do the spirometry before and after, or you can replace it with a peak expiratory flow.
I agree with Misal that most of the patients tolerate well if we provide a bronchodilator before starting the inhalation. However, if we choose patients that maybe they are old, the lung function is not as well, maybe in this patient I recommend to use the tolerability test, because, for example, from the papers that we have using mannitol and hyperosmolar agents, hypertonic saline solutions, we have I don't remember well, but it's not a small percentage of people who don't tolerate these tests. So yeah, for example, for the majority, it could be fine. But if you choose people that maybe have lower lung function, older, maybe it's good to do the tolerability test. And I would like to highlight again that not only the tolerability test, for example, I saw in my clinical practice that only a tolerability test at the beginning, and the rest of the time doesn't matter what happens with these patients, but they could have minor adverse events. It is true that they are minor, but if the intensity of these minor adverse events are high, they are going to stop doing this treatment. Yeah. So I think we need to monitorize these minor adverse events, and maybe we can also try to explain to the patients that these are the general minor adverse events. If you don't tolerate well, maybe you have to tell us, and we try to other approach, for example, to reduce the concentration of the hypertonic saline to 3%, for example, or even you adding hyaluronic acid to the solution.
Yeah, very good point. Before we close, I know we are getting to the close of this webinar, but there is a question that I find really interesting, and I wanted to ask you, Beatriz. So someone is asking for the patients with dry cough, what are your recommendations with regards to the with the airway clearance techniques? So if someone
Sure.
has dry cough, what would be your recommendations with regards to airway clearance techniques? I would really like your opinion on that. And if I could, I would have this as a voting as well.
If the patient have dry cough, I'm going to ask, have we got mucus plugs in the CT scan or not? It's because if we have dry cough and we don't have any evidence about mucus plugs in the CT scan, maybe this patient is not a good candidate for airway clearance techniques. Maybe we can provide other type of techniques more related to ventilatory techniques, but not airway clearance techniques. However, we need to be sure that we don't have any evidence about accumulation of mucus in the airways. And just to identify what is the etiology of this chronic cough. You are more expert than me on that, Arietta, so maybe you can add something in the topic.
Yeah, no, I always find this very interesting discussion because I fully agree. You need to be sure that this is not down to the technique being ineffective and not being able to bring the phlegm up. Is more about there's nothing there to bring up. So I definitely agree. You need to do some further investigations and make sure this is a true dry cough. In which case you would not need the airway clearance techniques, but you need to be certain. And also, I wonder if others see people who have actually a dry cough in some clinically stable phases of their condition, and which then converts into a wet cough with sputum, and then you need to have these airway clearance techniques in place for when they need them during an exacerbation. And I think this is a great discussion, but thank you so much for sharing your experience, Beatriz. It was lovely to have you today, and thank you for inviting me, Mikhail.
Yeah, so this is a really great question that I wish we had more time, but we're just out of time. So thank you both very, very much. And I just want to highlight the next webinar in our series, which is July 31st. And this is on radiology in bronchiectasis. So stay tuned and also register for that one. And thank you all very, very much. And see you next time. And for those of you who will come to Dundee, see you next week. Bye.
Bye. Thank you so much.
Bye. Thank you, everyone.